So now moving on to dementia. I'm going to go through the main types of dementia, so Alzheimer's disease, multi-infarct dementia, frontotemporal and Lewy-body dementia. And there are other causes of dementia besides these, and this includes things such as subcortical dementia and HIV, Creutzfeldt-Jakob syndrome, normal pressure hydrocephalus, and so on, as these can all present with dementia-like presentations. This diagram is helping to understand the difference between, say, an acute deterioration in cognitive function and how different forms of dementia may progress over time. And it's important to know that the most common cause of dementia is Alzheimer's, followed by vascular dementia. Mixed dementia refers to people who have both Alzheimer's disease and vascular dementia. And then there is Lewy-body dementia, which consists of dementia with Lewy bodies, and Parkinson's disease dementia. And then there's also frontotemporal dementia. And the other types of dementia account for 3% of dementia. So first of all, it's important to understand what dementia is. So by definition, dementia is an acquired, chronic progressive cognitive decline, which results in functional impairment. This is different from age-related cognitive decline, which is a decline in cognitive abilities associated with age without a significant functional impairment. However, some people who have what is initially thought to be age-related cognitive decline may actually have early dementia. A decline in cognitive function is characterized by quantified deficits in their memory, executive function, visual spatial function, language, or attention. And then these are a few definitions associated with cognitive decline. Aphasia is when a person has difficulty producing the name of, say, objects or individuals. They may refer to things as, or may refer to objects as thing and it, and they may repeat what is heard or repeat words over and over again. So repeating what is heard would be echolalia, and repeating words over and over again would be paliolalia. Apraxia is the inability to execute motor activities. Patients may find it difficult to perform known motor acts such as waving or combing their hair, whereas agnosia is a failure to recognize or identify objects despite an intact sensory function. So, with regards to the investigation of cognitive decline, it's important to do a history and examination, to do a mini mental state exam. And so these are things to identify whether or not a person has an actual cognitive decline. And furthermore, in order to rule out other differential causes of cognitive decline, you may do blood tests such as a B12 and folate, full blood count, ESR, and UNE. And again, this is to rule out differential causes, as a B12 folate deficiency can cause a pseudo-dementia-like picture. TSH, because hypothyroidism in the elderly can again present with a dementia-like picture. And because the causes of vascular dementia are related to diabetes, you may consider doing a HbA1c. HIV tests may be done in order to rule out, say, subcortical dementias associated with HIV. Syphilis serology may be done, as neurosyphilis can lead to a dementia-like picture as well. And then imaging is useful to rule out, say, normal pressure hydrocephalus or a tumor. It can help to confirm cerebral atrophy. Furthermore, an MRI can show cerebral infarcts in vascular dementia. So, as I've mentioned, there are screening tools. This is something known as the MOCA. I think it would be quite useful to get to grips with it and understand what it entails, as this came up in my final year OSCE. They may use another cognitive tool, such as the mini mental state examination or the 10CS. So, dementia history taking. When taking a dementia history, it's important to understand the onset of the dementia. So when did it first start? How did it progress over time? Are there any triggers, such as the loss of a family member, or do they first notice the memory problems or functional problems when moving to another home, or at say a yearly event such as Christmas, when they met all of the family, they maybe weren't able to identify people's faces, for example. It's important to identify if there are any associated features such as depression or psychiatric features such as hallucinations. Patients may have behavior problems such as agitation, aggression, wandering about, disinhibition, or calling out. Some patients may have disturbances in their sleep pattern. They may have things such as aphasia, apraxia, as I've mentioned earlier on. It's important to know what the patient's past medical history is, whether or not they have a past psychiatric history, history of diabetes or head injuries, or history of Parkinson's, in a Lewy-body dementia. It's also important to know what the patient's drug history is, to know whether or not they have medication which is meant to reduce the risk of, say, vascular dementia. Family history, as there may be a familial component to, say, to a person with Alzheimer's, or a person with, say, Huntington's disease. Furthermore, it's important to know what the patient's social history is and social living condition is. So if they live on their own, how are they with their ADLs, which refers to activities of daily living, what their occupation is, and whether or not they smoke or drink alcohol. So Alzheimer's disease, the most common cause of dementia in the UK, accounting for about 62% of dementia, and about 500,000 people in the UK. There are particular risk factors, the biggest being age. Other risk factors include family history, repeated head injury, low educational achievement, and Down syndrome due to trisomy of chromosome 21. Things which reduce the risk include smoking, surprisingly, anti-inflammatory drugs, and high educational achievement. Family history is associated because of mutations in APP or presenilin. And so the pathogenesis is thought to be due to the accumulation of beta amyloid and tau tangles. Beta amyloid plaque deposition occurs due to the faulty processing of the amyloid precursor protein, which is found on chromosome 21 and accounts for why people with Down syndrome have an increased risk of Alzheimer's. The amyloid precursor protein is processed by secretase enzymes alpha, beta, and gamma. These are encoded by presenilin 1 and 2 on chromosomes 14 and 1. Usually, APPP is cleaved by alpha and beta secretase into smaller non-toxic fragments. However, in some people, sequential cleavage by beta and gamma secretase results in the generation of aggregated proteins which cause the amyloid plaques. The tau tangles are due to microtubule protein tau, and so these are normally fibrillary intracytoplasmic structures which help to stabilize the axonal microtubules, and they run along the neural axons and are essential for intracellular transport along neurons. So essentially the microtubules are held together by the tau protein, and it's thought that the accumulation of the beta amyloid causes hyperphosphorylation of the tau tubules, leading to a structural and functional failure of neurons. Furthermore, Alzheimer's tends to be associated with a very characteristic cerebral atrophy of the frontotemporal and parietal cortexes, and degeneration of something known as the nucleus basalis of Maynard, which is the cholinergic center of the central nervous system. And so this helps to reiterate the degeneration of the frontal lobe and the parietal, more the frontal lobe in this image. Furthermore, degeneration of the nucleus basalis of Maynard, which is the main cholinergic nucleus in the central nervous system, contributes to Alzheimer's disease. Typical pathological findings include atrophy of the hippocampus, along with enlargement of the ventricles. And this just shows the senile amyloid plaques associated with Alzheimer's disease. So the presentation of Alzheimer's disease is typically associated with short-term memory loss. This can be very insidious and not so obvious. They may start off by misplacing things or leaving the cooker on. However, it's important to understand that this may just be age-related cognitive decline. The patients may the memory loss may progress over time, leading to a retrograde memory loss. So the patients may start to think that they're actually 50 years old or 40 whilst they're actually 80. They may think that they're currently living in a country or a place that they used to live in, or think that people who died are still alive. A decline in language, so they may have difficulty naming objects or understanding what people are saying. Impaired problem-solving ability, so they may have difficulty with simple written tasks or have a difficulty completing orders. And this is shown by the Mocha test. They may have an impairment in executive function, and so this means, so for example, if they were to go to the supermarket, they may not really know what to do. They find it difficult to plan and organize things in advance, and they find a significant difficulty with sequences. So they find it hard to understand that they go to the supermarket to pick things up, put it in the basket, they then push the basket to the till, the basket to the till, where they have to pay for it, and then they go back to the car. So this sequence of things they do, they may become very confused and not understand what to do. There are also neuropsychiatric symptoms. This includes things such as feeling very depressed or anxious and sad, wandering about, or becoming agitated and aggressive. And so there are different subtypes: early and late onset. Early is before 65, late is before 65. Early tends to be associated with genetic causes or genetic mutations. Late tends to be associated with an age-related deterioration. There tends to be different stages. So this is A, B, C, D, the stages of Alzheimer's. Amnesic first, so loss of memory, behavioral changes, the cortical phase, and the deceived phase. And so this diagram is essentially showing the different stages. So the amnesic phase, the patient has a loss of memory, short-term memory loss. This may then progress towards behavioral changes. So the person is very sloppily dressed, confused and disorientated. The cortical phase, in which the patient has a further deterioration in their cognitive state, leading to a potential deceived phase where the patient is permanently bedridden, unresponsive, may not speak at all, and may be incontinent as well. However, this would be quite late stage Alzheimer's disease, and not all patients deteriorate to this stage. With regards to the investigation of Alzheimer's disease, similar to other causes of cognitive deterioration or central nervous system signs, you want to do a history and examination, along with basic blood tests such as full blood count using these liver function tests in order to rule out differentials. You may also consider doing an MRI or CT scan. This would help to identify, say, degeneration of the hippocampus, along with enlargement of the ventricles and deepening of the grooves of the brain. Furthermore, an MRI and CT can be done to rule out non-Alzheimer's causes of dementia, such as vascular dementia or stroke, tumor, or hydrocephalus. There's something called a PET scan. This isn't typically done in practice. It helps to identify areas where there's reduced glucose metabolism. So this would be normal, where there is normal metabolism of glucose, and then in a person with Alzheimer's disease, there is an enlargement of the ventricles and reduced areas of glucose metabolism. And so the management of Alzheimer's disease, primarily it's the conservative management, the non-conservative, non-pharmacological management. This includes things such as helping the patients with dressing, eating, and cleaning, giving a setting that provides dignity, say a care home or living with a family member. Furthermore, the non-pharmacological treatment includes things such as cognitive stimulation therapy, where the patient is given a range of activities, say painting or playing music, or say even playing bingo with other people in the care home, in order to help to maintain their cognitive function. Behavioral management includes things such as anxiolytics, or such as SSRIs for anxiety and depression. Antidepressants, again, such as SSRIs for depression. Furthermore, antipsychotics may be prescribed in patients who are agitated or very aggressive in order to help with delusions or hallucinations they may have. And then there's also acetylcholinesterase inhibitors, or anticholinesterases. And so, because Alzheimer's disease occurs because of degeneration of the nucleus basalis major, which is the main acetylcholine nucleus of the central nervous system, acetylcholinesterase inhibitors can help to reverse and stabilize Alzheimer's disease. However, it doesn't completely prevent the deterioration. This includes medications such as donepezil, rivastigmine, and galantamine. Donepezil is contraindicated in bradycardia and can also cause insomnia or hypertension, salivary hypersecretion, and the development of sludge syndrome or cholinergic syndrome, which would consist of salivation, lacrimation, urination, diaphoresis, GI upset, and emesis. There is also memantine, and so memantine is an NMDA antagonist. This is used in moderate to severe Alzheimer's disease, and it's thought that glutamate receptors, the NMDA receptors, are overactivated in Alzheimer's disease, leading to excessive calcium influx, and and excitotoxicity and neuron death. So moving on to multi-infarct dementia, this accounts for 17% of dementia. It increases with age, such as similar to other forms of dementia. There are particular risk factors such as hyperlipidemia, hypertension, diabetes, and smoking, and these are general vascular risk factors. It tends to be associated with cerebral ischemia, and it's thought that cerebral ischemia occurs due to atherosclerosis, thrombosis, and vasculopathy. This ischemia then leads to gliosis and scarring, along with demyelination and a loss of cognitive function. And in some patients, this may be mixed with Alzheimer's disease. And so the typical characteristics association with vascular dementia is that it has a stepwise pattern. It leads to a successive cumulative impairment of multiple cognitive domains due to repeated vascular insults. An example that I have is on my psychiatry placement, I saw a patient with dementia that also had cataracts. When I met him, he was cognitively impaired, but it was not so severe. When he came back from his cataracts operation, it was much worse. He was much more agitated, much more. He had much more severe cognitive impairment. And it's thought that the reason why this happened was that when he had the cataracts operation, he was put in general anesthesia. The general anesthesia led to a drop in his blood pressure, and this drop in blood pressure on the background of cerebrovascular disease led to cerebral ischemia and a worsening of his vascular dementia. And so this sort of a stepwise deterioration in disease rather than gradual. So he had a sudden deterioration in his cognitive status rather than the gradual, sort of insidious over time deterioration associated with, say, Alzheimer's. These patients will also have evidence of or history of cardiovascular disease. They may have had multiple heart attacks, strokes in the past, renal vascular disease, CABGs, so coronary artery bypass in the past. The presentation tends to be somewhat variable because multiple different parts of the brain are affected. Early on, they may only have short-term memory loss. If it affects, say, the frontal lobe, they may have primarily cognitive dysfunction, neglect, or aphasia, and so on. And it's typically mainly divided into large and small vessel disease. With large vessel disease, it tends to be large vascular areas causing, say, aphasia or apraxia or disinhibition. If it's in the frontal lobe, if it affects, say, the hippocampus, it may lead to amnesia. If it affects, say, the parietal lobe, it may cause alexia or apraxia. Whereas small vessel disease typically affects subcortical areas, such as the thalamus and basal ganglia. Small vessel pathology is seen as a normal part of aging. However, in people who have vascular risk factors, this small vessel pathology is exacerbated, which can cause diffuse loss of myelin in these deep vascular subcortical areas, typically presenting with a loss of executive function, apathy, inattentiveness, and personality change. So with the investigation, similar to other causes of dementia, you want to do a detailed history and examination with an assessment of their mental function. You would also want to do blood tests in order to rule out differentials, MRI and CT again to rule out differentials. And so this image is showing a FLAIR MRI, FLAIR standing for Fluid Attenuated Inversion Recovery. This is useful if you want to bring out periventricular hyperintense vascular lesions. And so in this image you can see these areas of demyelination due to vascular ischemia. And so the management, there's conservative management similar to Alzheimer's, consisting of things such as cognitive stimulation therapy, antipsychotics, antidepressants, and so on. However, it's quite important to institute risk factor modification. And so the risk factor modification is similar to other causes of dementia, other causes of vascular disease. So this is treatment of hypertension, treatment of cardiac disease, hypercholesterolemia, diabetes, and proper management of stroke. Lewy-body dementia is divided into dementia with Lewy bodies and Parkinson's disease dementia. These are similar conditions with similar causes. However, the classification is slightly different. Lewy-body dementia accounts for 6% of dementia and is more common in men than women. It's associated with both acetylcholine and dopamine deficiencies. Acetylcholine deficiency, which is primarily in the temporal and parietal lobes, and low dopamine levels associated with alpha-synuclein accumulation in the substantia nigra, dorsal raphe, and locus coeruleus. So the clinical features of Lewy body dementia, there are 4 key features. These are repeated visual hallucinations, which tend to rapidly fluctuate. So this image is showing, for example, a person who's driving and sees a person sitting in the middle of the road. It tends to fluctuate, so they won't always have these hallucinations. There is a sort of delirium-like fluctuation in cognition. 10 minutes, a patient may appear completely fine. 10 minutes later, they may be very confused, very disorientated, and then another 10 minutes later, they may be no longer confused and disorientated. The Parkinsonian symptoms, so extrapyramidal symptoms. This includes things such as rigidity, bradykinesia, a gait instability as well, along with a tremor, a rapid eye movement, sleep disorder. So usually when a person has REM sleep, it's only the eyes that move. In Lewy body dementia, the entire body moves during REM sleep, and the patient may act out their dreams. And typically they may wake up with their bed sheets on the floor, or the person that they're in the bed with will complain that they're striking out at them. It tends to be associated with things such as frequent falls due to the gait instability, a loss of smell, excessive sleepiness during the daytime, and problems with visual spatial orientation. So as I've mentioned, Lewy body dementia consists of dementia with Lewy bodies and Parkinson's disease dementia. Dementia with Lewy bodies is when dementia occurs first or within a year of Parkinson's. Whereas Parkinson's disease dementia is when a person has dementia occurring after at least a year of diagnosis of dementia. The investigation of Lewy-body dementia, again, similar to the other conditions you can do, you would want to do a detailed history and examination, assessment of mental function, blood tests in order to rule out differentials, and MRI and CT to rule out differentials as well. There's a specific type of CT scan, that scan, which helps to visualize the dopamine transporter levels in the brain. And a person with who doesn't have Lewy-body dementia or Parkinson's disease, you would have a sort of comma-like picture. However, in Parkinson's disease and dementia with Lewy bodies or Lewy-body dementia, they look like dots rather than commas. So the management of Lewy-body dementia. So there's the supportive therapy. So similar to the other causes of dementia, speech and support groups, cognitive stimulation therapy, care homes, and treating patients with dignity as well. However, patients with Lewy-body dementia tend to have gait problems, and so in this case they may also benefit from physiotherapy or occupational therapy, in which, say, handrails or chairlifts may be installed in the house. There's the pharmacological therapy. This includes cholinesterase inhibitors. This helps to treat the cognitive symptoms because, as I've mentioned, Lewy body dementia occurs due to deterioration and reduced levels of acetylcholine. There's also carbidopa, levodopa. So a combination of levodopa and carbidopa. This helps to treat the extrapyramidal symptoms, and I'll go into detail with regards to this in more later on. And then there's also clonazepam, and so clonazepam can be useful for treatment of the REM sleep disorder. In these patients, you want to avoid giving antipsychotics, as it can cause a worsening of the Parkinsonian symptoms. So frontotemporal dementia. So frontotemporal dementia is a range of conditions which cause a range of sporadic hereditary disorders which affect the frontal and temporal lobes. It accounts for about 2% of dementia and tends to occur between the ages of 21 to 75. So frontotemporal dementia can occur in patients that are somewhat young. However, it tends to occur in patients between the ages of 45 to 60. 50%, about 50% of cases are inherited. It's associated with mutations of chromosome 17, which cause abnormalities of microtubule binding tau proteins. So the clinical presentation, it typically affects their personality, behavior, their language function. However, they have preserved orientation and motor skills. And I would like to emphasize that, say, in an exam question, the primary differential characteristics are changes in personality and behavior. So a person who has significant behavioral changes, which is very abnormal, which point towards a diagnosis of frontotemporal dementia. There are different subtypes. There's the behavior subtype, frontotemporal degeneration with motor neuron disease, and primary progressive aphasia. So this diagram helps to just break down the general sort of presentation of frontotemporal dementia. As I've mentioned, it occurs due to degeneration of the frontal and temporal lobes. The patients may have decreased speech, loss of awareness of their own personal hygiene. They may do things which are absolutely outrageous and socially unacceptable. They may have difficulty with reading things. An oral fixation can cause them to eat foods and gain quite a lot of weight. In particular, it tends to be very unhealthy food, very unfatty, unhealthy foods such as, say, cakes and biscuits and so on. A loss of empathy and doing things which are absolutely socially unacceptable and outrageous. It may seem that what they're doing is very selfish to other people, but to them it seems absolutely normal. And a bit more with regards to the subtypes, so with the behavior subtypes, the patients will have significant behavioral personality changes. This includes things such as overactivity, restlessness, being very disorganized, a very inappropriate demeanor, a gain of weight because of a loss of ability to inhibit themselves because they are unable to inhibit their appetite. The patients are typically unaware of how socially unacceptable what they're doing uh, is characterized by a major breakdown in social behavior and personal hygiene. Um, and then there are three subtypes of this, primarily disinhibition, apathy, and stereotypic behavior. So as I've mentioned, the disinhibition is things such as overactivity, restlessness, and inattention. The apathetic patients will lack motivation. They'll spend the entire day just lying down, not really doing anything. The stereotypic behavior, the patients may repeat things over and over again with very repetitive ritualistic behaviors. They may tell you the same story multiple times over and over again, and they may sound what is characteristically described as a broken record. Frontotemporal lobar degeneration with motor neuron disease. This typically occurs in men under the age of 5. It tends to happen before they develop motor neuron disease, and the motor neuron disease tends to lead to a rapid progression and death within about 2 to 3 years. There's also primary progressive aphasia. This tends to occur in women between the ages of 50 to 65. It's associated with a gradual loss of comprehension and ability to name objects. These patients may have a significant mental rigidity associated with stereotypic behavior. With regards to the diagnosis, again, similar to the other causes of dementia, you want to rule out the differentials. The neuroimaging, in particular the MRI and CT, will show degeneration of the frontal and temporal lobes, as shown in this image. So you have enlargement of the ventricles and degeneration of the temporal and frontal lobes. The management is mainly supportive, so as I've mentioned, the support groups, cognitive stimulation therapy, say antipsychotics or anxiolytics for anxiety or depression. And in these patients, cholinesterase inhibitors have not been shown to help